Thank you very much. Ladies and gentlemen, let's move on to our next lecture, an update on coronary CT. May I invite the moderators for this lecture as well, consultant cardiologist Dr. Vasantha Kapwatta and consultant cardiologist Dr. Prakash Priyadarshan to take the stage, please. Thank you.
Good afternoon, Professor Finto. Let me introduce our audience to you. Because of the COVID situation here, we are actually doing distance meetings here in our sessions in Sri Lanka Heart College of Cardiology. Today, our council is here, but of course, all over the country, there are transmissions going on. Several attendants are there all over the country. Let me introduce our speaker today. He's Professor Finto. He's a Dean, Faculty of Medicine, University of Lisbon. And he's Professor of Cardiology and Head of Cardiology, Heart and Vascular Department at the University Hospital, St. Maria. And without taking much time, I'll hand over to you to talk on CT, cardiac CT.
Good morning for me. Good afternoon for you. It's a pleasure to be here with you. Unfortunately, due to the current situation, I cannot be physically, but this way it's been now the current way of communicating. So I'm very happy to be here at your meeting. I congratulate you for your College of Cardiology and for the program, and I'm really delighted to be part of this faculty. So I will share now my presentation, and we will be starting to talk about coronary CT, which is one of the imaging tools that we currently have available for assessing our patients with heart disease. In particular, I will be focusing on coronary heart disease. First, this is a picture of my hospital in Lisbon, and we always delighted to have colleagues coming from all parts of the world. So when things settle down with this pandemic, I hope to have some colleagues coming here, visiting us and stay with us, so we can actually exchange some ideas and some opinions. So, as I mentioned, we are fortunate today to have all these different imaging modalities that can help us to establish better management strategies for our patients. Tomorrow I will be talking a little bit more about some of the other techniques, but today we'll be focusing on CT angio, which is a technique that has been around for quite some time, but has had some significant important developments and even potential indications that have been discussed, that have been basically looked upon through different studies. And today we have already some evidence to show some of the potential advantages on the use of this important technique. Well, one of the first questions that we have when we look at the coronary lesions is this a severe stenosis? That's relevant because we know there's a correlation between the severity of the disease on one hand and the outcome of our patient. At the same time, there has been already enough developments and enough data that shows that the diagnostic performance of multi-slice CT has been moving forward and improving from the old 4-slice to then the 64 slice, now the 320 slice multi-slice CT, with a sensitivity very close to 100% and a specificity over 90%. So we can say that the assessment of the native coronaries improved significantly, particularly with the introduction of the 64 or more slice CT scanners. And this actually helped a lot, not only in terms of diagnosis, but also to help to have a better assessment of the coronary tree. And again, not only in terms of stenosis severity, as I will show, but also in terms of assessing the quality of the plaque, the burden of disease, basically of the atherosclerotic involvement of the coronary tree, which, as I will show you, and as we know, it's an important component in the assessment of the severity of disease on an individual patient with diagnostic but also prognostic implications. And here we can see the prognostic utility of assessing severe stenosis by CT. And there is a correlation between the extent and the severity of coronary findings and the risk for the individual patient. Of course, this put together with some of the other risk factors that we know have an impact on the severity of coronary disease and also in terms of patient outcome. Uh, and then if we look here, the next question is, okay, we have stenosis, but is there ischemia? And for this assessment of ischemia, we have used over the last few years FFR or IFR to give us some information on the hemodynamic assessment of the severity of the disease. And this correlation between the severity of the stenosis with the presence or absence of significant ischemia is very important to determine the intervention on the specific lesion. And this has been, and I will not get into all the details, but as you know, there's been a lot of studies, and particularly the FAME study, that showed that by using some parameters and some thresholds for FFR, we could do better intervention and basically assess and show the lesions that will have indication for intervention so we can improve the outcome of our patients. On the other hand, it has been shown also that the severity of the stenosis by CT is not totally related with the presence of ischemia. And we've known that for quite some time also with coronary angiography. We have known that the correlation between the severity of stenosis and ischemia does not necessarily correlate. And that's the reason why there was a need to have some other parameters to help us to identify the lesions that will be hemodynamically significant and that should be intervened. And here you can see that there was, even for lesions more than 50%, there was a significant display of these lesions with different hemodynamic significance. And if you use this, the 0.75 cutoff, as you know, that is around 0.7 to 0.8 cutoff for the FFR, we can see that by using the 0.75, there's a widespread of lesions, more than 50%, that can fill into either above 0.75 or below 0.75. So this correlation is not totally clear. And that was the reason to develop also non-invasively some software that could help to identify, together with the CT, FFR. And there was a development with the heart flow of the FFR derived from CT for ischemia. And this combination would have, on one hand, the anatomic features, and on the other hand, the functional features by assessing FFR. FFR derived from CT for ischemia has been shown to be quite accurate. And although this is not widespreadly used, but clearly was an important development, an important tool, again, to show at the same time the anatomy and the functional changes related with the stenotic lesions. Now, the next question is, what is the extent, the severity, and the type of atherosclerosis? So is there, what is the quality of the plaque? What is the extension of the plaque? What is the burden, basically, of the atherosclerotic plaque, and how does that relate with patient outcome? So CT is actually the only method that can provide a whole heart quantification and characterization of coronary atherosclerosis, because it provides not only information on what are the consequences of the lesion in terms of lumen stenosis, but also provides information on the plaque characterization, tissue characterization of the plaque, extension of the plaque. So it provides information not only in terms of the severity of the lesion in the lumen, but also on the quality of the plaque, on the characteristics of the plaque, on the extension of the plaque. So basically providing information on plaque burden for the individual patient. And if you want to be a little bit provocative, we can say that atherosclerosis is actually what really matters. So the primary disease process is the atherosclerotic process. Stenosis basically is a secondary anatomic consequence of atherosclerosis. And we do know that in the early stages, there is this plaque accumulation with expansion of the vessel. And only at later stages, we will have some repercussion in terms of luminal stenosis when the disease is already very, very much advanced. This is more or less the rule, although of course there are some exceptions. And then ischemia is basically the tertiary physiological consequences of the presence of atherosclerosis plus stenosis with flow limitation in the coronary vessel. So the evaluation of coronary artery disease beyond atherosclerosis focuses on byproducts and end-stage disease. But in reality, what really matters is what is the underlying process, meaning what is the underlying atherosclerotic process on the individual patient. It has also been shown that the absence of atherosclerosis by CT, it does provide some important information because basically it shows that this patient will have a very low likelihood of developing an event over 10 years. And here we have different studies that basically show that if there is a normal CT without atherosclerosis, there is a very good prognosis for that individual patient, and the absolute event rate is very low in this patient without significant atherosclerotic lesions on the CT. Here again, there is some evidence of the prognostic utility of coronary atherosclerosis by CT. You can see that if there is the presence of three vessel disease, and this again was a study with more than 2,500 patients, and if there is three vessel disease, even if it's mild coronary disease, these patients, they have less than 50% stenosis in the assessment by the CT. But if there is involvement of the three vessels, there is a six-fold higher mortality for three vessel disease on the average of 3-year follow-up. So the extension of the disease is also relevant, even if there is no significant stenotic lesion. And again, here you can see the all-cause mortality. And if there was presence of plaque and significant plaque, there was a twofold higher mortality for the addition of plaque, regardless of the stenotic lesion. So the presence of coronary atherosclerotic lesions and the severity of these atherosclerotic lesions in terms of the extent of the involvement of the vessel has important prognostic implications as well. And here you can see what has been called the confirmed risk score that has been developed by looking at more than 13,000 patients, again, followed for average of 3 years, looking at clinical risk factors, severe stenosis, and atherosclerosis, but no severe stenosis. You can see that it was the presence of atherosclerosis that could identify the higher risk patients in this study by using this confirmed risk score, which basically looks for the atherosclerosis on the presence of disease in the left from the different coronary locations. And this was actually a better tool to assess the severity in terms of risk assessment for the individual patient. So it's the atherosclerosis that is relevant to assess also the impact of the disease on the individual patient. And the type of atherosclerosis also matters more than the amount of atherosclerosis, and this has been shown in the ICONIC study. And when the angiographic extension of the coronary disease and severity is the same, the atherosclerotic plaque characteristics are relevant to individualize in terms of prognosis the individual patient. So here it was a comparison between patients who experienced acute coronary syndromes after CT angio and patients who did not experience. And what was shown in this case was that when look at calcification or fibrosis, there was no significant difference. But when looking at the presence of fibrofatty plaques or necrotic core, the patients who had acute coronary syndromes, they had a much higher percentage of fibrofatty content of the plaque or necrotic cores. So again, it was also the quality of the plaque that was relevant to individualize the patients who had worse prognosis. It is also interesting to see that with this technique, actually, the presence of atherosclerotic lesion, the quality of the lesion, it does enable some assessment of what could be the future culprit lesions. And here you can see that you have the non-culprit and the culprit lesion, and the difference is that the culprit lesion has a much bigger positive remodeling, as the presence of a necrotic core, as in this case, minimal effect on the lumen, and there's a high atheroma volume, so there's a high burden of disease compared with the non-culprit lesion, which has positive remodeling but no necrotic core. There's a minimal effect on the lumen as well, and is more of a focal lesion. So the quality, the extension, the characteristics of the plaque may help us to identify potentially lesions that may be future culprit lesions on the individual patient. And these plaques that look different, they also act different. And we've known for some time that, for instance, the presence of very significant calcification, it's a marker of atherosclerosis, but actually are the lesions who are less calcified, lesions who have necrotic cores, who have lipid cores, who have more fibrofatty content, that are the lesions who may actually evolve into acute coronary syndromes. And at some point was actually mentioned that calcification actually could reveal some sort of scarring of scar tissue, if you will, or scarring of the vessel. And this could actually be a marker of stable atherosclerotic lesions in comparison or in opposition to the lesions who have a higher lipid content, necrotic cores, and these are the more severe, the more risky, the more dangerous lesions. Now, this Credence study, the Credence trial, was actually looking at particularly at the atherosclerotic component to see what will be the best method to determine the vessels that may actually be more severe in terms of evolving into events and into acute coronary syndromes. So here in the Credence study, basically these patients, they were divided. They followed this protocol. It was the largest multi-center international trial, and more than 600 patients at 13 sites. And basically what it showed was that looking at these three different models, the model that used the combination of stenosis severity with the qualities of the atherosclerotic plaque. So by looking at stenosis severity, number of lesions with more than 30% stenosis, presence of non-calcified plaque volume, high-risk plaque, and lumen volume, these were the ones who had more capacity to discriminate the lesions that would exhibit significant ischemia, and that could actually evolve into some potential events in acute coronary syndrome. So again, not only the presence of lesion, but more important, the characteristics and particularly the severity of the atherosclerotic lesions in relation to the presence in the vessel, the extension in the vessel, that will be relevant to assess what will be the significant impact of these lesions on the individual patient. Now, an interesting development has been the use of machine learning for CT, and this is some interesting studies that have been done. Again, this is a study that was published a couple of years ago, and using different sites, and basically by using machine learning to detect FFR, and with very good accuracy, with good sensitivity and specificity, the use of these parameters have actually, and this can actually be very relevant in terms of the future developments and future evolving of this technology. So machine learning applied in this case for CT for the assessment of ischemia. And the question is, if can machine learning based FFR improved substantially by using basically all this amount of data that can be collected from different studies. And here you can see that by using this, and this was in more than 10,000 patients, and looking at different variables, And by using all these different elements, that was actually with very good sensitivity and specificity to predict clinical outcomes in these patients by using these different parameters and basically by using all this big data, all this amount of data, and translated into algorithms that could predict with good sensitivity and specificity the clinical outcome of the individual patient, again, based on stenosis severity, location of the lesion, extension of the lesion, quality of the atherosclerotic plaque, putting all this together to have this prediction of clinical outcomes. And in fact, machine learning is particularly good at cardiac CT. And it's good at classifying which stenosis is more than 70%, which plaques can cause heart attacks, which plaques have necrotic cores, which plaque features together increase the risk of heart attack by doing association rules, by ranking which plaques can increase the likelihood of ischemia, how should these findings be reported, and what features are most important, because basically by having all this amount of data and putting it into these algorithms, it can provide a lot of interesting information. And again, this is something that is ongoing and certainly will improve the way we can use these tools to help us to do better patient management. Now, another important feature of CT is the ability to look at grafts, bypass vessels, and this has been particularly useful if you want to have more precise location of the grafts, if you want to do a redo surgery, and grafts they have larger diameter, and they tend to move a little bit less and have less calcifications than native coronaries, and they are easier to image. And you can see here, very nice, this is a Lima, this is a saphenous venous graft. Here you have very nice, it's another Lima here, and you can see nicely the distribution of the graft and also the characteristics of the graft. So it's another use of CT. Here you can see nice with the 256 slice CT angio, the graft imaging. You can see nicely here and here. You can see the distribution, the presence of lesions. And then you have here what is called a cardiograph 560 slice CT, where you can actually also look at the stents. You see nicely here one of the limitations on the early machines was the difficulty in looking at stents. And now with these very advanced capacities, you can actually have also a very nice look at the lumen inside the stent and be able to assess how much it impacts in terms of lesion severity, distribution of plaque, and so on. And then there's been also some interesting developments on image fusion. So basically having or hybrid imaging, having the ability to use different imaging modalities, CT with PET, CT in this case with echo. This is an interesting combination of coronary CT with 3D stress echo. Basically here the goal is to have an anatomic technique, which is CT with a functional technique, in this case the stress echo, 3D stress echo. So basically you can correlate the functional changes like induced ischemia and correlate that with the anatomical lesions or with the anatomical features that are related with the functional. So you can at the same time have an anatomic, morphological, and functional assessment. And this is one of the examples. Some other examples like PET-CT can also today can also be used and basically provide, again, this complementary information of function, anatomy, and if you use PET, also metabolic assessment of the myocardial tissue. And let me finish with giving you also information on the guidelines. So the presence of significant data has been used in the guidelines. On the first guidelines for stable coronary disease in 2013 of the European Society of Cardiology, the CT angio was a two-way recommendation. So it should be considered to rule out stable coronary disease in patients in the low range of intermediate pretest probability for stable coronary disease. And then in the more recent ones, in the 2019 guidelines for what is called now chronic coronary syndromes, coronary CT angio plays a central role. So patients with angina or dyspnea and suspected coronary disease, these are the recommendations with the latest guidelines. So if there is a low clinical likelihood, if the patient characteristics suggest high image quality, if there is local expertise and availability, information on atherosclerosis is desired, and no history of coronary disease, the use of CT angio is now recommended. And then, of course, it goes through all the different elements of the algorithm to decide if the patient goes into coronary angiography and potential intervention. And here you have now the recommendations. Non-invasive functional imaging for myocardial ischemia or coronary CT angio is now recommended as the initial test to diagnose coronary disease in symptomatic patients in whom obstructive disease cannot be excluded just by the clinical assessment. And this is a 1B recommendation. And if you look now also, the use of coronary CT angio should be considered as an alternative to invasive angiography if another non-invasive test is equivocal or non-diagnostic. And again, this is a two-way indication. And finally, there is also EACVI, the European Association of Cardiovascular Imaging. They have a certification process for training in cardiac computed tomography, and now it's provided annually, this certification process, and this can be done at the EACVI. So in conclusion, the use of CT has evolved over the years. Now we have very important developments. We have data to support the use of the coronary CT angio. We have indications for diagnostic purposes, for patient management of coronary with patients with, particularly with stable coronary artery disease. And certainly this will be a technique of the present and a technique of the future that can help us basically to help us to do better management in patients with coronary, with suspicion or even with known coronary artery disease. And I will finish now and be more than happy to answer any questions from now on. So thank you very much for your attention and thank you for the invitation.
Professor Pinto, so there's one question. What is your experience in triple rule out protocol in acute setting of chest pain patient coming to ETU using triple rule out protocol? Is it being used there frequently or?
Well, this is a very important question, and certainly this protocol certainly depends on the conditions that you have in your local setting. This has been shown as we know to be if you have the right conditions, this can be applied, and with very good sensitivity and specificity can actually rule out patients with acute chest pain. And there are specific algorithms where you can use this algorithm to basically help you to identify the patients with acute chest pain, and which, as we know, is one of the main reasons why we have patients coming into the ER, and many times without it's difficult to predict if you are in a busy center. The issue many times is because CT angio in many places is not a cardiology technique, is very much shared with our radiology colleagues. So it's important that locally you have very well established protocol, so this can flow in a very smooth way. There are centers that apply it as on a routine basis. There are centers that apply it in certain conditions or in certain instances, and there are centers who have more difficulties in applying it because of particularly of the settings or the local logistics. So I would say that if you have the right conditions, either if you have the CT angio in cardiology, or if you have a very dedicated center that can basically be on a 24-hour basis to help you to use this strategy, that it can be used, and maybe it should be used, because basically by using these rules, you can easily identify the patients and then basically do the identification of the patients that have to go into coronary angiography, or the patients you can discharge with a comfortable result. So that will be my recommendation. If you have the right settings, go ahead and organize a protocol to use it. If not, I would be a little bit more cautious, because this needs of routines and needs to have a very well linked relation, particularly between radiologists and cardiologists.
Professor Pinto, thank you for this excellent presentation. One more question from the audience. They asked, what is the role of CT in an elderly patient where the calcium score is very, very high, and how you interpret? And I add on to it, in our setup, the younger people get more atherosclerotic disease. Do you recommend CT for these two kind of people, either older and younger?
Well, I think today, and as I've shown, and as the guidelines show, CT angio can help you on one hand to identify the severity of the lesions, can even give you some functional information, and particularly in the patients where you may have some questioning about the severity of the implications of the lesion, it may help you to identify those patients that may benefit them to go into invasive coronary angiography and do the invasive study. So I think it can help you to risk stratify the patient and help you to identify the patient that may benefit of an intervention. So I would say that in both scenarios that you mentioned, it can be useful, and it's again, it's an important tool that adding to the clinical profile of the patient, the metabolic profile, and so on, it can help you to risk stratify and help you to identify the patient that then you should take into the cath lab or not, or just follow medically.
Thank you, Professor Pinto, for your excellent presentation. We learned a lot from your presentation. As there are any more questions, we, as a member of Sri Lanka College of Cardiology, we thank you very much for your time spent to educate us. Thank you very much.
Sure, my pleasure. Thank you. See you tomorrow.